the program at the University of Texas Health Science Center, San Antonio.
Brett Johnson, Program Director for the Residency Program at Methodist in Dallas.
And then why don't we start just the front row and work our way back in the audience. So I'm really surprised all these Texas Tech people are here and not in Minneapolis, where the Final Four is going to be happening. I guess they got on the wrong plane when they were coming down. And I need to ask if anyone is joining us on the phone. If you'd...
Yeah, this is Jim Donovan. I'm the Chief Medical Officer at St. David's, Georgetown.
Great. And Dr. Foxhall, have you made it on the phone? Okay, so we're expecting Dr. Foxhall to join us via telephone as well. So we have a number of voting items right off the bat, and we're going to defer those a little bit and see if Dr. Foxhall can join us. And so we're going to come on down to the consideration and discussion of the financial reports, and Dr. Unger is going to present that information. Fred?
Thank you, Dr. Reagan, and thank you for the opportunity that you've given me to be able to go through these numbers. It's quite a bit of information, as you can see, and you have a report in front of you with the information that you need to be able to follow along. It can be very confusing because all GME programs are not created equal, and so just bear with me, and hopefully I'll be able to answer any questions that you may have at the end of the day.
Hello.
Dr. Foxhall is here,
Hi.
Very good.
Anyway, this is Fred Unger presenting the financial report, so we'll continue on. Welcome.
Great. Thank you. Thank you very much.
So just like I was saying, bear with me, and if you have any questions, hopefully we'll be able to answer them together at the end of the day. Another thing I want you to know is that don't try to compare your numbers or your residency numbers with anybody else's, because they're not, like I said, all GME programs are not created equal, and financial institutions have different arrangements for different programs that may not look quite like yours. So the only number that I can say that remains the same, if you guys have this sheet right here, this shows you the trend from the formula funding for per resident funding for every year for the last, I would say, 10 years, since 2010 and 2019. And so you can see where we've been. We've been as high as $14,564 per resident. Those were the good years. I think all was good back then. And we've been as low as $3,800 per resident in 2013. That was probably one of the worst years we've ever had. So that kind of gives you a big picture perspective of where we are as far as formula funding is concerned. And then we'll continue on from there. The good thing about this exercise, it allows us as program directors and chairs, family medicine and administrators to be able to look at one another and say, hey, what are you doing differently from what I'm doing, so that we can hopefully learn from one another as how to improve our revenue streams, and if we're having any issues with maintaining some of the revenues that we have, we can look for opportunities to be able to do that. So this is really the purpose of this exercise. that is something that we can also talk about at the end of the day, just have an open discussion if that's necessary, to be able to learn from each other as to what everybody else is doing. We currently have, at the bottom, if you see on the first page, 773 residents that were funded by the coordinating board in 2018, the fiscal year. We are now down 2 programs. If you see North Central Texas Medical Foundation, that's the Wichita Falls program, is no longer in existence. And the UNT Bay Area Medical Center, the first page, also is no longer in existence. So these were monies that were appropriated by the coordinating board. This time when these monies were appropriated, these programs were still in existence, but I believe Bay Area closed in 2018, that was their last class, and North Central Texas also, Wichita Falls, closed in 2018.
Both closed June of 18.
June of 18. So we had 773 residents that were supported last year, and I will cut that countdown on each column and what everything means, and if there's any questions, please just wait, and at the end of the day, we'll be able to discuss them together. So if you look at the total revenue column, which is the next thing that we're going into, there's a lot of disparity among the programs, with a wide range coming from $1,049,000 at TCOM, the University of North Texas program. That's an NMM, that's the neuromuscular manipulation program, all the way to $23.3 million at the Conroe Medical Education Foundation. That's the Lone Star program. Now, I'm going to explain later why those numbers look so different, and so just bear with me. One of the main things why we have such disparities, if anything, on a bigger scale, is because we have different funding programs that most institutions have. Some tap into federal grants, some tap into local grants and local monies that other programs don't have. And then the arrangements on how that money is expended is also different at different programs. Some people don't have anything at all, and you're going to see that later as we go along with this. I should also point out that the Conroe program has significant federal dollars from the FQHC status, and so if you're not one of those, don't compare yourself to them. That contributes quite a bit to their total money. I have to commend most of the programs because of the financial governance that they've shown, and we continue to remain viable, even though we have very little to work with. I think a lot of the residency programs are doing a tremendous job of generating revenue from direct patient care and related services, but also using the grants that we have in a very responsible manner to keep our programs afloat. The highest earners, if you look at the programs that we have there, like Conroe and JPS and Memorial Houston, these programs, what they've done very, very well is to be able to tap into the local grants better than some of the programs have. And I think it's just the availability of funds in their environment makes them a little bit unique. JPS has also an added advantage, which is just the sheer numbers. When you have 67 residents working, you can make quite a bit of money with that huge number. So that explains itself. The total number of revenues that we had on the next column is $202,831,000 and some change. The average across the programs is $6.994 million per program, not a small number. And then on the next one, we have the coordinating board operational grant. This is one of the fixed numbers that we have, one of 3 fixed numbers that we have in every year. So this is what this is actually talking about. This is the operational grant that we get from the coordinating board. So that number is fixed per year, is determined. It is approved and recommended by the Family Practice Residency Advisory Committee, which is, you're looking at it right here, based on the funds that are allocated to residency education by the Division of Strategic Planning and Funding for the from the Texas Higher Education Coordinating Board formula funding recommendations. Based on my calculations, and as you can see, this last year, each resident got $6,236, and actually about 90 cents on top of that per resident. And you can take that number and multiply that with the number of residents you have, and you'll have the coordinating board grant. It should add up. If it's not adding up, and especially if it's less, then you need to let Suzanne know that you need your money. She'll
Could I interrupt you for 1 second?
Go ahead.
We did get a message from our control room that whenever anyone here at the table is not speaking, please turn off your microphone. They're getting a bit of feedback.
Thank you.
Okay, thank you.
So once again, you take that number, the $6,236, and multiply that with your number of residents, and you come to the Coordinating Board Operational Grant number. We can flip to the next page or the next column, and that's the public health and rural health grants. Now, those are the other fixed numbers that we have that are actually awarded by this committee right here. Only one program took advantage of the public health grants to the tune of $4,000. That is about $2,000 per resident, and that's the UNT-TCOM Family Medicine Residency Program. Now, 9 programs participate in the rural health program. The allocation for this is about $2,500 again per resident, and that is also done by this committee. Texas Tech Lubbock had 7 residents, and Baylor College of Medicine and UT Austin Dale program had 1 each. Okay? The approved and reported rural and public health columns, that's the next column after that. You may ask yourself what's the difference between the reported and the approved wordings mean. And basically, you may have a rotation, be it public health or rural health, reported, but if it was not approved, you may not be able to get the funding. Basically, what happens, some programs send a resident somewhere for rural health, for example, and then after the rotation is done, we find out that the program or the rotation itself did not meet the basic standards that are approved by the coordinating board. Whenever that happens, we have to hold them to the standard to be able to disburse that money. They would have to either return that money, and so that is not an approved rotation in that case. Okay, they have to either return that money or that money will not be sent to them if it had not already been sent, and that's the difference there. So they must meet the criteria that's been set by the coordinating board before that money can be sent out. The approved rural health and public health column dollars show about $102,500. This doesn't quite add up. If you put the $4,000 together with the $87,500, that comes to about $91,500. But well, what has happened is we did not shift the $4,000 that we get from the public health, the TCOM program, the Family Medicine Residency Program, and if you add that to the bottom line of the $102,500, it comes to about $106,500. Now you see, what color is that? Is that red or is that? Is it purple? It's red? I'm sorry, I don't do color very well. The red color on the Wichita Falls program, that's North Central Texas Medical Foundation, shows $15,000. That money was approved, but it was not expended. And so that money was either sent back to the coordinating board or will be sent back to the coordinating board.
It was not awarded.
It was not even awarded. So if you.
It was awarded but not paid.
But was not paid. Okay, so that's the difference. And that should bring us to about $106,500. So that's a typo right there, just a mathematical error, and it's not a big deal. We know where the monies are. Some institutions do not apply for the rural health and public health grants because of affiliation problem. You may ask yourself, why don't we have so many other programs applying for this? One thing, the monies are limited. It's not a big wallet full of money. There's so much money that's been appropriated for this. Number 2, different programs have different affiliation agreements with the residency environment, be it the hospital, the sponsoring hospital, be it the medical school. And so some programs do not allow residents to leave and go work somewhere else. Okay? We at Lubbock, for example, have to struggle with getting these things approved with the University Medical Center, which is our teaching hospital. But we've been able to work our way around it. And really, they do lose money whenever our residents are working away from the program. The only difference, we try to give them a little bit of money from the coordinating board to try to offset some of that loss, but it's really obviously not enough. So look at your institutional operating policies, and that, if you guys can change that, maybe more people can take advantage of these rotations. We can say that from looking at these numbers and knowing what we know, what we have available, we could probably have more people going out for rural and public health rotations.
Could I just add a comment? And
Go
that
ahead.
is, for the institutions that are over their cap, they might argue that they're losing money, but they're really not.
Yeah. That's a good point. It's a very good point. So let's go on to the next column. That's the coordinating board grant, the total coordinating board grant. And this is the sum of the operational grant plus the public health and the rural health grant. So if you add those three, they come up to the total of the coordinating board. So it's pretty self-explanatory. Okay, the percent of the total grant revenue, which is the next line, and you see some brackets around above those numbers there. Basically, those are numbers that were approved by this coordinating board. I think we have some explanations in your packet that you can look at whenever you have a minute. Okay? The coordinating board total grant divided by the total revenue on the first page should come to the percentage that's listed at the bottom. And so the percent of the total revenue per program is about 6.27%, which is not that huge, with some as low as 0.8% and some as high as 3.36, 3.94%. And we have UT Health Science Center San Antonio at 5.9%, 0.01%, which is pretty significant compared to the other ones. Next is the unexpended funds. You guys have that on the next column. These are basically monies that were disbursed to the programs, but they were not used. Any program with a positive balance means that they have money that needs to be returned back to the coordinating board or will be returned back to the coordinating board. UTMB and UTL Science Center Houston had positive numbers in this column, okay? There's 3 programs that also had negative balances in this column as well. That's Baylor, College of Medicine, UT San Antonio. And what this means that for the ones that had a negative balance, basically, they had to dip into their own pockets to be able to balance out their operations in the institution. So it's not money that was lost by the programs or money lost by the coordinating board. It's basically money that those programs had to expend above and beyond what's allowed for them or what's been allotted for them. And so it's really actually a positive thing if you really look at it from that standpoint, that the institutions are willing to shell out extra money to be able to meet their needs. Okay? The outlier here is the North Central Texas Medical Foundation. That's the Wichita Falls program, which has about $15,000 we talked about earlier. This amount was approved, but was never sent out. Okay, so the money is still with the coordinating board. So I would say please spend the money wisely, because if you don't, you have to bring it back. Next, and I'm going to talk about this a little bit later on as well, there's interest paid on the coordinating board grant. Well, we appreciate you, UT Tyler. Are they here? They obviously put some money in the bank and got some interest off of it. Well, send it. That's our money. Send it back.
They already have.
They already have, good. At least you're watching out for the master's talents. If you know, we don't fault you for that. That money belongs to the coordinating board, so the money has been sent, okay? And some people do that, put the money in the bank and comes back into positive cash at the end. Let's turn to the family practice residency program patient revenue. And once again, you see such tremendous variability here in the numbers, with Conroe at $15,615,000, all the way down to 0 in some programs. Now, why do we have zeros in some of these programs? For example, Baylor College of Medicine in Houston has 0. Scott and White Temple has 0. These are monies that come from both direct patient care in the hospitals and direct patient care in the clinics, and other locations wherever they may be getting their monies from with patient care. Unfortunately, some programs do not have the benefit of being able to report that money because of the way the institutional affiliations are, the institutional agreements are. So you may see 0 there. That does not mean that the residents are not working. The residents are working. You know, they have to meet the $1,650 bottom line for every resident in 3 years. Only that the way their affiliation is with the institution, wherever they are, that money is not reported in any ledger showing as resident income. So it's not, there's nothing we can do about that, but at least we know that the residents are working, because definitely the ACGME approves those residency programs to keep on going. There's also tremendous variability, like I said, but it all depends on the structure those institutions have in place to be able to affiliate with the residency program. Any questions on that? Okay, let's keep on rolling. The patient care revenue per resident amounts to about 38% on the average. As you can see on the next column. Once again, we've already taken out the zeros and we explained what they are, and we also have the interest there already. We discussed that. And I think everything pretty much adds up and is self-explanatory beyond there. Some institutions are making pretty good money, $446,000 per resident. Once again, the Conroe program. JPS 351 is pretty close, but that's just sheer numbers. They're not an AHEC or an FQHC. And we also have McLennan County, which is the Waco program at $230,000. Those are the ones that are leading those categories. The next column is a medical school revenue. Each program, once again, has a slightly different arrangement with the affiliation. I'm sounding like a broken record here, but it is what it is. We have to explain why we have such numbers and such variability in the numbers. Once again, all institutions are not created equal. Some have more money than others. Some give more money to family medicine than others. So each program has a different affiliation with the medical school. And so the actual amount that comes to the program is based on the agreements that the medical school have with the program. This could range from student health services to teaching medical students in the clinic, in the hospital, or both. The medical school structure is also they also have arrangements with some of the medical schools to pick up any differences that the programs may have, especially when there's losses. There's some medical schools that have actually agreed to defray or at least pay in order for the institutions to meet their bottom line, which is really good for some places, for some residency programs. As you can see, we have programs who get nothing from the medical school. That's probably because they're not involved in direct medical student teaching or patient care or even student care, health care in the institution, to as high as 77%. UNT, College of Osteopathic Medicine, that's a neuromuscular manipulation program, gets 0. UT Rio Grande Valley gets 43%, which is pretty significant. The average here is about 10% at the bottom of the page. So those two programs really are leading, which is the TCOM program and the Rio Grande Valley. They're way ahead of everybody else. Next is the hospital and local revenue. Again, like a broken record, this is going to vary based on the composition of the program, and affiliation agreements with the hospitals is what we must say in order to explain what we are doing. As a percent of the total of the hospital and local revenue, and when we say local revenue, there's some grants that some institutions have within their local communities. It could be foundational money coming to those institutions. If you know how to get where the rest of us can get some, we'd like to know. Please share. If your rich uncle or rich aunt can share with us, we'd like to have that money as well. So if you have some local funds that you think can be extended to other programs, please let us know. Okay, as a percent of the total of the hospital and local revenue, the range is wide, starting at 2% at UT Rio Grande Valley to 97% at Bay Area Medical Center. Once again, Bay Area Medical Center closed and they were at 97%. But now the leader in this area is Scott & White, which is doing at 96%. They average about 50% across all programs. And you guys can see that number at the bottom of that page. Okay. So we have the amount per resident of the local revenue. That's the next column. Once again, Those are monies that these programs have, divided by the residents, you get the number at the bottom. There's really not very much to explain there. Once again, I think the one thing that you can encourage is the ones who are getting $393,000 of hospital and local revenue. You have to remember some of those programs, some of those monies are combined monies between the hospital and the local revenue, but really, for the most part, for UT Rio Grande Valley, it's all local revenue. There's no hospital funding there whatsoever. And once again, we think it's because they're not involved in direct patient care or, student teaching and stuff like that. It's also one of our newer programs, and I think that is something that is understandable. Next is the hospital revenues. The range is from $0, once again, at the UT Rio Grande Valley and the neuromuscular manipulation programs, and to a large sum of money. And I think these are some of the hospital-based programs like the Waco program, the JPS program, the Spawn Corpus Christi program. These programs have large sums of money at $10.79 million at Waco, and JPS is at $7 million. Corpus Christi Spawn Memorial Program is at $6.2 million. And these hospitals do a very good job of underwriting some of the cost of running these programs. And they should be commended for that work that they're doing. They obviously see the value of the residents and the residency program in the institutions, that they spend a lot of money to keep these residency programs afloat. All right, the next line is the local revenue. As you guys can see, Baylor College of Medicine has $1.34 million. UT Houston has $4.11 million. Big numbers. And then the Amarillo program, they are not telling us something. The Texas Tech guys in Amarillo, $978,000. It's quite a big sum of money for local grants, local money. We'd like to know how you guys are getting it, so let us in on it. A special track. Okay? Can you explain more? Oh, yes. Okay, that makes sense. They have some residents from Saudi Arabia, and obviously they come with a big check. Yeah, let us in on it. We'd like to have some of that. Most programs here really have zeros next to this, and so it is self-explanatory. Okay, now the federal revenues. You guys see that? And these are basically the Waco program. The Conroe Lone Star program has $5.13 million, and that is because of the FQHE status. They're able to do a whole lot more, and they also pay them monies about the Medicare rates, and that can lead to a lot of cash really quickly. And then down at the bottom, we have UTMB at $66,894. All the other programs really don't have any federal revenue at present. There's also the other revenue category, and I guess the Saudi Arabia program would fit into this. And I'm not quite sure what the other programs are doing to be able to get other revenue, or what the nature of those other revenues are, but they can be pretty significant. And as you can see at the bottom, Texas A&M program has $2.3 million of other revenue. UT Southwestern, $2 million, and then McLennan County, the Waco program at $1.5 million, and UT Tyler at $1.2 million. Quite a bit of money. All right, next is the total revenue. Once again, this is all the money is put in the pie before any costs or anything are taken out. The numbers are there in front of you, and this is basically adds up to, once again, the coordinating board operational grant, the rural health grants, the local revenues, the hospital revenues, and everything put together, adding up to the total revenue of that catch. And then there's other revenue category. I'm not going to spend too much time on that. All the programs combined, all the 29 programs, came to about $720,000. And then the revenue minus cost, which is cost taken away from the revenue. In anybody's ledger, that will be profit. It comes down to about $5.3 million. If you divide that by 29 programs, you're going to come up with a number. You see three programs there in the red. Basically, the Dell program, which is UT Austin. There's a huge number. Waco program, the McLennan County program is $943,785. That's a huge number. And then there's an even bigger number at the bottom, which is the Valley Baptist program down in the valley. Now, These programs are not at risk. We've reached out to this program and noted that the monies were balanced out by the institution. So none of these programs are at risk. They are still operational and they're doing well. So it is not a concern. Once again, the Wichita program, which is the North Central Texas Medical Foundation, is now closed. So that number is no longer important on the list. Next is basically a repetition of what we've done. Except now we're looking at costs. 773 residents total, minus 23, and at Wichita Falls, and another 10 at, how many? 5 at Bay Area. So you're looking at 28 residents lost that now no longer in existence. And we're going to ask if there's any other programs out there that are applying for funding. I think we should have one coming up for funding this year.
We'll actually handle that item a little later in the
Yes,
agenda
okay, so we'll
in terms
talk about
of our
that.
next
Yes,
meeting.
yes,
But you're correct. There are some
yes.
programs that have awaited the appropriate length of time and may be
Yes.
looking for funding.
Maybe this time they may get some funding, which would be really great. So if you look at the total expenditures per program, it's huge variability. And these people like Waco, because of the FQHC, not Waco, Conroe, because of the FQHC status, they really have some huge expenditures because they provide so many different services out there. Waco is next at $16 million. Memorial Medical Center Houston is $15.6 million. And then way at the bottom, we have 2 more programs, the A&M program and the Santa Rosa program in San Antonio also have huge numbers that they're expending. So total cost per resident, as you can see, just divide those numbers by the number of residents in the residency programs. You come with those numbers at the end, and it all comes to about $264,819 per resident. Pretty significant amount. All right. The next line is the resident cost. As you can see, the bigger the program, the bigger the coffers, the more expensive it's going to be their residency program. And the numbers, once again, they're pretty self-explanatory. Now, a program like Dell was kind of one of those things. We had 21 residents at $1.6 million resident cost, for example. You know, you wonder, and the total cost, percent of total cost is 49%. It's not an outlier, but it's really getting to a point where it's almost pushing that line of about 50% based on the recommendations that we put in the coordinating board. And so that somebody is really pushing that ceiling. Before too long, they're going to be in the red. They need to watch that very, very closely. And this is information that they can use to be able to see where they are compared to everybody else. Now, we also have some people who are below the ceiling, which are those red lines that you're seeing over there at Conroe and McLennan County, Memorial Medical Center in Houston, and in the teens. And so, once again, this is information they can use to compare themselves to everybody else and see where they haven't missed opportunities or opportunities to be able to do better and improve their systems. The faculty cost per, at the residency programs, they total to about $62,393,000. And every program they're listed, we have them as low as, forget the zero there, but $133,000 at the neuromuscular manipulation program at UNT, all the way to $2.9 million. Actually, at McLennan County, we had $4.2 million, which is a pretty significant amount. Now, some of the programs have more faculty really than others, and you find them with a small number of residents, but they have a huge number of faculty. So the faculty costs may be huge, but some of those people are not necessarily working directly with the residents. We'd hope that everybody that's reported here is actually working directly with the residents, and if they have one encounter with the resident, that may be factored in here. So these numbers may be skewed a little bit. After doing my research, I've found some of those people have a minimal contact with the residents, but they're having some contact throughout the year with the residents. So all that is dumped in here. So these, once again, may be skewed to the left or skewed to the right, just depending on what these guys are actually doing within the institution. The average of the total is about 32% at the bottom, so you guys can see that. The faculty cost per resident is about $85,786 per resident. Next is the personnel costs. These are the people that support the structures that we have in place. The numbers are right there in front of you. $44,656,954 for all the programs combined, averaging to about $1.5 million per program as far as personnel cost is concerned. And these are the support staff, once again, the nursing, the PSS or patients services, people who answer the phones, and whatever you guys have within your programs, okay? The personnel cost per resident is about 1.6 million total, which is about $55,153 per resident. So it's a huge, significant amount. And then the operating expenses to run every single program average about $1.3 million per program. Moving forward. And that's just really, I'm not going to spend too much time on this because these are relatively small numbers compared to everything else that we're doing. And that's the clinic and office costs. You guys can read that on your own. And other costs, which is just miscellaneous costs. And at Memorial Medical Center, they have almost $400,000 of other costs. I don't know what that is. I'd like to know what that is. And once again, the Conroe program, I can see that with all the services that they provide. I can see a $250,000 worth of expenditures in other costs, but I cannot explain the $400,000 at Memorial Medical Center. Once again, they probably provide these residents some Ferraris each, so they can go on with that upon graduation. That'll be nice. It'll make me go back to residency.
Maybe 2 Ferraris.
You get 2 Ferraris at your program, huh? All right, so really, to summarize this thing here, this is really a demonstration of the fiscal responsibility that we have, not just to our learners, but also to the public, also known as the taxpayer. These monies come from they're expended through the coordinating board, but really the biennium puts the money together to be able to determine how much money is going to higher education every year. And so we have a tremendous responsibility to make sure that the monies are expended properly and that we have accountability for every single dollar. And as you can see, out of $202 million, there was a 400+ interest that was gathered from one of the programs. The money had to be sent back to the coordinating board. The money does not belong to the programs. You know, I would like to take that money and put it in the bank for the whole year and then go to work with the interest, but that money belongs to the public, so it has to be returned back to the coordinating board. So what this does, it just gives us an opportunity to exercise tremendous due diligence and make sure that all our systems are in place and they're working appropriately, and that we're using the lean method to be able to get the most out of the little money that we have. And so I would like to commend the administrators who watch this money very closely. All the stakeholders are involved, the department chairs, the program directors, and even the residents to a certain extent, to make sure that everything is done properly. What this opportunity gives us, as I was saying earlier, is a chance to be able to compare ourselves with other comparable programs and decide if we have opportunities that we are leaving on the table, if we can talk to the coordinating board to help us with other opportunities that we can use in order to be able to improve the revenue streams within our programs and try to provide more services to our public. And so I hope that this was helpful in some way. I know it's a lot of self-explanatory material, but sometimes it helps just to hear it from somebody else who's actually taken time to analyze the data a little bit closely. That concludes my report. Thank you very much.
Dr. Unger, thanks for that report. You know, the financial data, along with the annual written report, is always very interesting, seeing the ways that programs come to grips with the finances. GME finance is very complex. One takeaway is that programs are getting it done lots of different ways, which is interesting. I think there's some good things to take away from that. This is a voting item, so I would entertain a motion to approve the financial reports.
So moved.
I have a motion and a second. Any further discussion on the financial reports? All those in favor of accepting those as presented, say aye.
Aye.
Opposed?
Aye.
So, thank you. Thank you, Dr. Foxhall. That stands approved. And Fred, thanks for spending the time on that. I know it took some time to get through that, so I appreciate your efforts on that.
Thank you.
I have a housekeeping item before we move on to the other items of business. For those that are members of the advisory committee, you will find a purple form at your place. Please fill that out and return that to Suzanne before you leave today. It's just estimated expense report. Our next item is also a voting item, and that is consideration of the selection of chair and vice chair for fiscal year 2019. And so the floor is open for nominations, and we'll do chair first and then go to vice chair. Anybody want to nominate someone for chair? I've been reading about political figures. I think the way you say this is, I'd be happy to do it if drafted. I won't be offended if I'm not drafted, but I'd be happy to serve. Okay. Any other nominations? You know, there's like a line of people and everybody steps back and there's just one guy standing there.
I move that we close the nominations.
Okay, so normally we have the vice chair run this part, but we don't have one. So, or I am, I guess. But there's one nomination for chair. Yeah, one nomination for chair. Myself, Mike Reagan. Those in favor say aye. Aye. Opposed?
Aye.
Thank you. Thank you. Okay, so I'm happy to serve. Now we have nominations open for the vice chair position. Anybody hankering to serve?
I nominate Fred.
Okay, so Dr. Unger has been nominated as vice chair. Any other nominations for vice chair? Hearing none, we will vote on the position of vice chair. Dr. Unger is the one nominated. All those in favor of Dr. Unger, please say aye. Aye. Opposed?
Aye.
Congratulations, Dr. Unger. You are vice chair. So with that item of business out of the way, we'll move on to the next item of business, which is consideration of the summary notes from the April 11th meeting. You'll find those in your packet. Any amendments or changes need to be made? Hearing none, I'll ask for a motion to approve those.
So moved.
I have a motion and a second to approve the summary notes as presented. All those in favor say aye.
Aye.
Opposed?
Aye.
So they stand approved. Thank you. We moved through that fairly expeditiously. Thank you. I have the honor of presenting to you the annual reports, and just as I said about the financial reports, the data is very rich, and it strikes me that it would be useful for program directors in some way. I'm not sure how we would get that in the hands of program directors, and I don't think it was written to be used that way necessarily, but it is some rich data. I'm happy to present it, but just think about that. So the annual written report has a number of different questions, and I'm going to cover the ones that are germane and have some substantive reports. The first area is around whether or not the program is increasing or decreasing in size, and I have good news to say that most programs are pretty stable. There are a few who are decreasing, and I think maybe one that's increasing in size. The reasons for that were primarily funding, worries about funding on the two that were decreasing. One program was shifting to a different accreditation cycle with a different agency from AOA to ACGME, and so that explained those numbers, so that wasn't really a concern. One program was involved in a pilot program, fourth-year training at John Peter Smith, and that is the reason for the shift in the numbers on that one. And then one program reported that they increased their size temporarily because of increased service demands on their hospital service. I thought that was interesting, that was out there. You know, you always wonder service and education balance, that kind of thing. When you look at the relationships of the programs to medical schools, it's really all over the map. And I'm not 100% sure that everyone is reporting the same way. So there's not really a lot to draw from that. Almost all of the programs, but one, reported that they had third-year students rotate in their residency. I presume because it's nice to have 30 years that you can recruit to your residency. That's a valuable thing. Interesting that one program did not. Almost all of those programs reported that they didn't get funding for that. There were a few that did, but many that did not. And it's difficult sometimes to tease out the financial relationships around that. So I don't know if there's much more to be made of that. In terms of the activities to attract underrepresented populations to your residency, it seemed like a lot of programs are hedging and worried about the legality of how that works, and that's probably appropriate to be concerned about that. They did describe a variety of different ways to approach this, and so those are probably worth hearing about. Most programs talked about residency fairs, family medicine interest groups, presentations, attending national meetings, that kind of thing. Some programs highlighted their diverse faculty, residents, and patient populations as tools to enhance the recruitment of underrepresented populations. One program talked about participating in JAMP and SNMA activities and had faculty members speaking at those various events to try and garner some interest. One program talked about AHEC participation. A program talked about working with local foundations, but I'm not sure about any more details than that, but that's kind of interesting and unique. One program spoke about targeting applicants who lived in health profession shortage areas or medically underserved areas for at least 5 years as a metric in their recruitment. So they include that in their scoring. So that's kind of interesting. One program mentioned attending recruiting fairs at diverse medical schools as a strategy. And a program mentioned diversity training for their faculty and residents. So kind of different viewpoints there. In terms of meeting the legislative intent of the Family Medicine Residency Program to further the distribution of family physicians and improve medical care in underserved urban and rural areas, a lot of interesting entries. Many programs discussed informational and encouraging type activities with their residents. Some programs had requirements, others had active rural and public health rotations. Some programs focused their responses around clinical programs that they provide in the area, such as free care or care in group homes or in penal institutions, in jails, and so that was interesting. One program said they invite rural communities to resident meetings to help assist in recruitment of residents to those rural areas, so access to the residents for recruitment. The FMAP program at Texas Tech was mentioned several times. A number of programs had developed rural tract programs for their residencies, and 2 programs mentioned a required rotation with the health department as a way to reach underrepresented populations. So there's kind of a mixture of how that question was answered. Another section in this part of the report talks about other exposure to underserved populations, and many programs talked about their patient mix, in particular ones that have federally qualified health centers, many involvement with free clinics. There were some rotations in underserved areas away from the primary program, rural sites for rotations for many programs, school-based clinics as a location of care was mentioned. A number of programs talked about overseas medical missions to underserved populations around the globe. One interesting approach was looking at outcome data relative to the graduates of the program and where they're practicing. And that program mentioned using the Graham Center to report on that data. So I don't know if the other programs have done that. It wasn't mentioned in the reports, but it might be interesting to see where the graduates of your program are working. I thought that was an interesting idea. Barriers to participation. Many mentioned that the cost of living was not supported by the stipend, that a lack of interest from residents, and that some oversight organizations were concerned about residents being gone, essentially. That was one of the barriers to that. Innovations. Now, this was by far my favorite part. Very interesting data in this. A number of programs mentioned using CPRIT grants to enhance procedural training either in endoscopy and or women's health around cervical cancer screening and treatment. so using the CPRIT grant to help support the training. One program mentioned serving as a regional hub for also course training. There was a mention of a standout residency quality and safety curriculum. A number of programs are using simulation centers to enhance training. Many programs are using grant funding to support innovations in training. There were a number of programs that mentioned the 1-2 format for rural track training, first year in the home program and then 2 years out in a rural area. A number of programs discussed clinical innovations, such as a discharge clinic to assist in the coordination of care after hospitalization. And one can imagine trying to partner with hospitals around support for funding, but also providing the clinical care. It's kind of an interesting idea. Many programs have embedded mental health and behavioral health within their clinical programs. Several programs mentioned leadership training for residents. There was mention of Spanish language training for residents. Some programs were focused on managing underserved populations and had really cool programs around assisting their patients. Food security, for example, enhanced by using a produce prescription. I don't think I've ever written a produce prescription, but I might. That's kind of a cool deal. A number of programs had extended hours clinics to assist patients in being seen. Many programs highlighted their recognition as a patient-centered medical home. There were some programs that spoke of pipeline issues of enhancing medical student education and primary care through longitudinal activities. Presumably the family practice residency program faculty involved in training students in a longitudinal fashion. Kind of a neat deal. Several programs mentioned that they were training sites for other healthcare disciplines like behavioral health or pharmacy. Those partnerships certainly would be interesting in the care of patients. One program mentioned they were participating in a cancer survivorship program through MD Anderson, kind of a neat innovation. The next section is on challenges. And I bet you not a soul in here can't guess, they will be able to guess what the biggest challenge is. Money, right? Absolutely money, right? Almost every entry had something to do with money, resources of one kind or another. There were a few that were different, and they're probably worth mentioning. But clearly, finances are the most common concern among program directors. And you can see that in the financial report by the complexity of trying to pay for medical education. It's very tricky. But the ones that differed. One program stated that graduating medical students appear to be less prepared than they need to be. I think that's probably been reported every year in the summary comments that I can remember. It seems like that's a common concern. Several programs mentioned difficulty recruiting and retaining faculty. Also, programs mentioned difficulty recruiting residents. One program mentioned they were frustrated that medical schools seem to actively discourage entry of good students into family medicine. There was mention of difficulty in caring for complex patient populations and difficulty in serving disadvantaged patient populations with many poorly met social determinants of health. Several programs mentioned difficulty in their clinical space, not having enough, or that the space needed significant updates. Several programs mentioned balancing of education and service, in particular concerns about duty hours. There were programs that mentioned difficulty meeting delivery requirement numbers and programs that mentioned small pediatric patient numbers. Some programs mentioned that their structures mean that the residents are employees of the hospital, and so it makes it very difficult when you're trying to do an away rotation like a rural or public health rotation because they're employees of the hospital. That's kind of a unique situation. And then the opioid crisis was also mentioned as a significant challenge. In terms of the last question, how can the Family Medicine Advisory Committee help? Big theme here is advocacy of family medicine broadly, and in particular around the funding for training programs. There was discussion about maintaining or working to restore or increase funding for family medicine residency training. There was a particular request around the primary care expansion model and the difficulty of it not covering and guaranteeing all 3 years of training because of the biennial piece of that. And that is just a reality it's brutal. And I think it's worth bringing to the conversation that it makes it tricky One of the programs mentioned that their sponsoring organization was not willing to let them expand because of the uncertainty. And so that certainly is a piece of this, I think. One suggestion was to educate the legislature on the amount of charity care provided by the residency across the state. I'm not sure that the financial documents capture that in a granular way, but it is an interesting thought. What is the dollar value of that? Might be something worth considering. Along those lines, a respondent also asked that we collect data on the increasing struggles of safety net practices like the family medicine residency programs. One asked that we make the process of public health rotation support simpler, and the example used was creating a process that's similar to the program letters of agreement. I'm not exactly sure what the intent was there. I think some of that's legislatively set for us, but some concern about the complexity of that. We had 2 respondents who asked for contact from the committee, and I'm not sure if they checked the wrong box or if they really wanted contact. I did reach out to them, and I did not hear back from either program director, so don't know if we'll keep after that and see if we can learn from them. But so very rich data about what's going on in the programs. And the broad takeaway that I have from reading the annual reports is lots of innovation, both around education, around recruitment, around care of underserved populations. It really is an impressive list of the things that you all are doing in your programs. It's very, very cool. So I enjoyed getting to read that. And that's all I have for summary. I'm happy to answer questions if anybody has any.
It was
This is Lewis. If I could, just had a comment.
Sure.
Thank you. So I think we got a mention on your report there, but I did want to point out that our CPRIT grant around managing cancer survivors, which we've been running the last 3 years, and this is using this Project ECHO methodology out of New Mexico for tele-mentoring. And we've been working with UTMB, UT Dell, and the UT Tyler programs. And we've submitted a renewal expansion grant with CPRIT, which would add in San Antonio programs in the RGV area and another program up in Northeast Texas. So I did want to be sure to mention that, just so you're aware of it. And another one of those areas where we can partner to help provide additional support and education training for our residents.
Dr. Foxhall, thanks for bringing that up. I think it's there's various venues of trying to pull down the CPRIT funds for different training. It's a neat thing to consider.
You were talking about recruiting of underrepresented minorities into residency positions, and I was wondering if the question spelled out the makeup of who that. Did everybody use the same definition, I guess, of what's underrepresented minority for these questions?
Let me find that, and I'll tell you what it says. It says describe your recruitment activities to attract underrepresented populations. So I don't know if there's a lot of definition around that question.
Yeah, so I guess my point is, so people likely use different definitions to answer that question. Whatever you think the definition is, that's what you use to answer the question, right?
You know, I think if you were going to criticize either the financial reports or the written reports, that is one of the challenges, is trying to get apples to apples comparisons is pretty difficult. And I remember, it's been a while now, but there was great effort to try and standardize the financial reports. And when you read through them, it's pretty clear people are answering it differently. And I think they've really put a good foot forward to try and spell it out. A number of administrators were involved in that activity, but it's just hard to get people on the same page. Definition's a great idea in terms of trying to define that, but that is, I think, the challenge with this data.
But staff can look into that and see, if we can do some research and see if there is, see what's out there.
Yeah. Good. Other comments or questions? So hearing none, I'll call for a motion to approve that report. Have a motion and a second. All those in favor, say aye. Aye. Opposed, nay? So that stands approved. Well, thank you. Okay, so I think we're down to item 6 on the agenda, the legislative update from Tom Banning, CEO and Executive Director of the Texas Academy of Family Physicians. You ready for us? You bet. Tell us you're going to get all kinds of money for the programs.
Can't hear if Tom's talking.
Is that better? Sorry. Sorry, Louis. So we've got more money, about $9 billion in new state revenue, $15 billion in GR. The leadership has made really 3 major priorities overriding issues this session. 1, public education, 2, property tax reform, and 3, Hurricane Harvey. And when you look at the House budget bill that was passed last week and the Senate budget bill that was passed out of committee today, it proposes to spend about $9 billion in public education and $3 billion in property tax cuts, and somewhere in the tune around $1.5 to $2 billion in Hurricane Harvey relief. So most of the available revenue that we were hoping for have gone to those 3 priorities. The legislature has put about $60 million in additional revenue into the GME expansion grants to maintain the 1.1 to 1 GME positions to medical school graduates, which is a good thing, and I think the coordinating board has some information in your backup material that you can look at to show that we are doing a much better job of opening up new programs and expanding existing programs to meet the needs of Texas and to keep up with the medical school production that we've got. The coordinating board had in their legislative appropriations request an additional $2 million to go to the family medicine or family practice residency program funding. The Academy had asked for $10 million to get us back to historical trends. To date, the funding is maintained from 18-19 budget in the 2021 budget, so no new money. That does not mean that once the House and the Senate goes to conference that more money may become available when the comptroller or when the controller lays out his new available dollars based on budget projections. 2 other areas that I think are important to highlight. 1, the preceptorship program, the statewide preceptorship program, both the House and the Senate have maintained $3 million in funding for those programs for the biennia, and the physician education loan repayment program, which I believe the coordinating board is going to talk about as well. There's I believe a rider that would restore funding that was cut in the last budget. There's also a bill that would index or increase the amount that eligible physicians or physicians eligible for the program could receive, going from $160,000 to $180,000 over a 4-year term. Lastly, I will mention that there's one bill and one rider in the being discussed on creating a rural rotation for Texas to try to get more physicians out to rural communities, and I believe there's $1 million tied into that rider for the production of new rural rotations, kind of based on what Texas Tech has been doing out in the Permian Basin and in some other areas. And other than that, you'll have to wait till tomorrow when I talk to the Faculty Development Committee so I can be a little bit more political. So I'm happy to answer any questions.
Thank you. Any questions for Tom?
Great. Well, I look forward to seeing many of you tomorrow.
Oh,
Go ahead.
we do have one.
I had a question. So can you repeat again with regards to the GME funding? Are you saying that it is maintained or they increased it?
So for the GME expansion grants, they've increased it by $60 million.
So it has been increased?
Yes, so I believe the total's now, and I might get this wrong.
157.2.
I thought it was 180, but so Suzanne corrected me. So yes, it's 157.
And again, I brought this up 3 years ago or whenever this whole thing started. Bienniums don't match up to PGY 3 levels. Was there anything that they made with relation to, I know at one point there was a discussion of putting together it into a funding so that way programs aren't at risk of committing to an expansion that could potentially be pulled later?
Constitutionally, they cannot appropriate funds outside of the biennium, but they have created a fund to draw from and are committed to do it. But there's no guarantee that the legislature won't come in and cut funding for or reduce funding from the $75,000 per slot at some point in the future, but that's not happening this session. And I certainly understand the position that the...
And do you happen to know, are there any discussions as to how that GME funding is supposed to be divvied up?
The programs apply to the coordinating board. The coordinating board has a formula that ranks those program applicants based on state need, on specialty, and then makes a recommendation back to the board, I believe. Suzanne, is that correct?
That's essentially correct. I'm going to speak on that on item number 9 on the agenda.
Okay. And then, all right.
Other questions for Tom? Thank you very much.
Thank you so much.
Appreciate the information. Now we're down to item 7, update on the Faculty Development Center. Cindy Passmore, Executive Director of the Faculty Development Center. Cindy, you want to give us a report?
I do. I think this is still on, correct? First of all, thank you. Thanks again for continuing to support us, for being such good friends of the Faculty Development Center. You all know, and there's a lot of people behind us that are also, a lot of guests here today that are big supporters. We do what we do for you all, and we couldn't do it without you all. So, as you can see in your packet, that there's a lot of numbers and a lot of programs. I talk about what we do, but essentially, what we do is the fellowship, which is now a graduate certificate. I'm shorter than Tom. This is a little harder to read. There we go. There. Graduate certificate in academic medicine. That fellowship is ongoing, as it has been. The only year we missed was the, we did not have a class in 2012 when I moved up to Fort Worth, but since we've been in Fort Worth, when we finish this year's class, when they graduate in June, we'll have 49 graduates in 7 classes, which is right at our historical average of around 7 residents per year. We're looking like we're going to have a really big year next year. My has challenged me to double the enrollment, which I decided to take as the lowest enrollment we'd had and double that instead of the highest enrollment we'd have. But it's looking like that could happen. We may have as many as 14 fellows, which would be a challenge for us, but a good challenge in the good way. So that's ongoing, and we continue to enjoy the support from the dean, and we couldn't do it without that happening, without these funds here at the coordinating board, nor our local funds that keep us going. Besides that, we do several other things. You all know tomorrow is our leadership conference, the Family Medicine Leadership Conference, which has been going on for decades, and you all continue to attend and seem to find that very useful. And please let us know if you want us to do anything different. We want to be responsive and try to be responsive to your needs. The other program that is annual that we do every year is the Chief Residence Leadership Conference. That continues to be very popular. And this year, sort of kind of towards, right as we were beginning to do our publicity for this, this year's Chief Residence Conference, we decided to add a little piece to that. And what we've done is we've decided to include residency program coordinators and directors, if they would like to come for the first day of the Chief Residence Conference, so that they can, all three pieces of the team can interact together around issues like communication, job description, just general skills, leadership skills, and particularly the job description and what the expectations are from the program director and what the chief resident kind of thinks the program director would ask of them. And we've had some subscription to that, not as much as we'd like, but we hope to see this continue. And it came about kind of outside of our team, some other coordinators that were doing a study got involved with us. But anyway, it looks like it could be very useful. So we're going to have a few people at least show up for that. The other programs we do preceptor training twice a year. Once we'll do one this upcoming Saturday, and then we do one during the annual session of TAFP. TAFP, we need to thank them too. They have continued to be very supportive of the Faculty Development Center and our efforts. And we train probably somewhere around a dozen preceptors a year, maybe more, sometimes more, sometimes less. But it's worth our time, I think, because when someone does come in and get 2 or 3 hours worth of just basic clinical skills, teaching, training from us, they go into the preceptorship feeling more confident about doing the job well. Other than that, we do on-demand or contracted training for any family medicine residency program or department. So if anybody wants us to come to their program, you have to pay our expenses, but we will come and we'll do whatever you ask if we can. We go to several programs we go every year, and then there's some that have never called us. We keep waiting, but they don't call. But we're willing to do that. We do things as typically we do things around communication skills and clinical teaching, but we've done curriculum writing workshops with folks. We've done things where we kind of tried to tease out what is the next accreditation system, what are milestones, back when we were all just first hearing about milestones. And so we'll do that. Just contact us and we'll answer the call and do what we can. Let's see, there was, so I think in the fiscal year 18, we ended up with just those other trainings. We had 470 trainee contacts in a year. So it is subscribed to, but just not by all the programs. The other announcement I have has to do with the staff. There are 3 full-time staff members, and we finally got the 3rd one, came on this year. So Sharon Manson, who, if you're coming to Sharon and Allison showed up. They were driving all the way from Fort Worth, so they got here a little bit after we had introduced ourselves. But if you're coming to the leadership conference, you've heard from Sharon, and because she runs that part of our programs. And our new staff member is Allison Silvius, and she joined us in January. And we're glad to have her. She's energetic and keeping us on our toes, and we need that. So the 3 of us stay very busy. We do have some part-time support from an administrator type, and then we have some other from one of our other, Jessica Chavez. She helps us with some of the some of our programming, but mostly it's the three of us and then who we can bring in. So, any questions?
Well, so I think it's a great resource for the state. Really, really pleased that you guys are going strong, and thanks for all you do. A lot of folks in the room have a debt to y'all from being former fellows in the past, so thanks for all the efforts.
You're welcome, and it is at your pleasure that we serve. Thanks.
All right. Our next item on the agenda is an update on the Physician Education Loan Repayment Program. Stacy Johnson, Program Manager, Loan Repayment Programs at the Coordinating Board.
Okay, hello. I'm here just to give a brief little presentation update on the Physician Education Loan Repayment Program. The program was actually created in the 69th Texas Legislature in 1985, and as of August 31st, 2018, we have enrolled over 1,500 physicians into the program. The program provides loan repayment funds totaling up to $160,000 over a period of 4 years on behalf of the qualifying physician on a graduated scale. Physicians may receive up to $25,000 after year 1, $35,000 after year 2, $45,000 after year 3, and $55,000 after year 4. The main purpose of the program has always been and continues to be to recruit and retain primary care physicians in health professional shortage areas. Applications from physicians practicing in applications from subspecialists are considered in the last quarter of the year if funds are remaining after all primary care physicians and HPSs have been enrolled. In addition, an alternative pathway was created by the 83rd session of the legislature for primary care physicians not practicing in HPSs or correctional facilities to apply for funds, and applications are considered after all primary care physicians and subspecialists have been considered and if there are available funds. And these physicians must meet required service levels for Medicaid and Healthy Texas Women's Program enrollees. The current definition of primary care specialties are family medicine, internal medicine, pediatrics, geriatrics, medicine pediatrics, OBGYN, and psychiatry. And as you can see on your handout, there are currently 402 participants in the program enrolled through February 28th of this year, which was our last quarterly deadline. Of those 402, 41% are family medicine physicians. And also of the 402, 109 or 27% are practicing in rural counties. An additional 34 applications in HPSs have been received since March 1st and are currently being reviewed for eligibility. And that is basically the entire presentation. Because currently we have an online application, and those links to our application and our administrative rules are on our program webpage, and I'll be happy to answer any questions.
When people are applying through the website, is it pretty easy to tell like, if their location is going to fit into the parameters?
Under the frequently asked questions, there is a link that they can go to the HRSA website and enter the address of their facility to see if it is located in a HPSA. And if they are not able to do that, they can always contact us and we can look it up for them.
One of the biggest problems we have in residency education is recruiting physicians to come and help teach. One of the questions that I've had recently was if there's funds available for those who choose to come into medical education, as far as being attending physicians are concerned in residency programs. Do you have monies available for such applicants?
If they're attending physicians in a residency program?
Yeah.
If they are providing direct patient care to patients of their own, then yes, they would be eligible if they're practicing or seeing at least 20 hours of direct patient care per week. And I think we're still researching about whether or not if they're actually supervising residents, that would count as direct patient care. We're still trying to get some clarification on that type of thing.
Another question, just to follow that. What if they choose to go to Dallas, Texas, or Houston to teach?
It would depend on if their facility is in a health professional shortage area.
So, in other words, if they go to a place where, for example, I went to UT Southwestern, so I'm going to use them, which is not a health professional shortage area, and they choose to teach there, they would not qualify.
Correct. They could possibly qualify for the alternative pathway if they're providing primary care, and they are seeing Medicaid patients. They could possibly apply for the alternative pathway.
So do we have a written statement somewhere where they can access that information to be able to see if they meet the criteria?
I can provide you that information, and there's frequently asked questions on our website, and we have a link to our administrative rules as well on the program that are on the website.
Thank you.
Thanks for this information. Also, I had another question regarding the loan repayment for faculty that might be eligible to participate. Is there a certain HPSA score that, like, for example, we practice at an FQHC but are not employed by the FQHC, so is there a specific HPSA score that's needed? Do they need to be employed by the FQHC?
Currently, the HPSA scores would only come into play if we have to rank applications, but in the past, we have had enough funding that we haven't had to apply ranking criteria, but should we get more applications than we have funding, then one of the ranking criteria is the HPSA score.
And is the employment status of the faculty member important? Do they have to be employed by the FQHC? Could they be employed by a medical school or a hospital system? And if they're practicing in that facility that's HPSA eligible, would they be eligible for this loan repayment?
As long as they're providing at least 20 hours of
20 hours
direct
a week.
patient care.
Okay, great. Thank you.
Your question raised a question for me to ask, and that is, you said we've had funds available. Are we spending most of those funds on loan repayment through the process?
Yes, sir.
Okay. That was one of the worries, I think, in the past, was we couldn't maybe not expend all the funds, but as it was expanded to subspecialists, we're able to.
Correct.
Okay. All right. Any other questions? Thank you very much. Appreciate the update.
Thank you.
The next item is the board update. Suzanne's going to do that one.
First, I have some good news. We have some additional funds that are coming to the coordinating board for the family practice program. So we are going to do a reallocation and give out some small amounts to each program based on the original formula that we used in the fall that was decided by this committee last year.
The formula that goes by number of residents, is that?
Yes,
Yeah.
yes. So we have about 200,000 right now. We're waiting for one more portion of funds to be returned before we can actually go ahead and do that. So it's not going to be a whole lot of money per resident. I mean, it's going to be less than $1,000 per resident for sure, but it's something. And if we don't reallocate it to the programs, then it will just go away, go back to general revenue. So we're working on that. Sorry to give you such a small amount of money this second time around, but you know, hey, it's something. So be on the lookout, you program directors, be on the lookout for that in the next couple of weeks, I think. It's not final yet, but it's going to be at least 200,000 and maybe a little bit more for the total amount that we'll have to then divide up by the 749 residents. Yeah. Okay. Second item I want to talk about is we have additional graduate medical expansion, education expansion awards that the coordinating board made in January of this year. There is a list of those awards in your packet. The total was about $3.5 million for 46 different residency positions. The next page gives you a little bit higher summary. We had 12 programs awarded total, then the 46 positions in those 12 programs and $3.5 million. Family medicine was 3 of the 12 programs, and primary care and psychiatry were all but 3 of the 12. So 9 of the 12 were primary care and psychiatry programs. So that is where we are right now. We are in the process of verifying all of the positions for the GME expansion program. The way this one works, I mean, unlike family medicine, where every fall you send in your rosters and we verify those and we then base our funding on the formula, for this grant program, the applicants send in an actual application based on a request for applications. And if they meet the criteria, then they are selected up to the point that we have funding to cover. So this secondary award that was made in January was a very small amount, but we had awarded the previous year just over $94 million in that program. And that was a total of, I believe, 63 programs that got that money. So in the fall, when we will be doing this GME expansion program award process again, we don't know what the final appropriation is going to be, but as Tom Banning said earlier, right now, what's in the Senate and the House budget, the proposed budgets, is $157.2 million. And that is $60 million extra over what we have now for this year. And so that, according to the coordinating board estimates, that is enough funding to continue the programs that were started in 2014 through 2017, and also take on some new programs that are going to start up new or expand for the first time during this program. So we'll see. I mean, it seems that the thinking is that that amount of money is going to be the final, but I have no idea. So we'll give you an update at the next meeting, which will be 2 or 3 days, I think, after session closes. One other thing I wanted to mention about the GME expansion program, we have some family medicine programs that have either expanded or have started up brand new programs with the support of money from that GME funding. So far, none of those programs have applied to participate in the family practice residency program. One issue was that there's a 3 years of operation requirement. Any program that participates in family practice grants has to be operating on its own for 3 full years. So we are now to the point where there are some programs that meet that requirement. And the committee decided at the last meeting, this time last year, that because it was mid-biennium, not to make any drastic changes. So you decided to take that on this year. So we will have that on our agenda for next meeting, May 29th, so that the decision can be made whether to bring those programs in or give people a choice to do one or the other, or whatever any other ideas that you all may have. So I want you just to be thinking about it between now and then, because it has implications, and it's maybe a good thing from the point of view of bringing all the family medicine programs together. That's a great thing. But as you heard earlier from Tom Banning again, we may not get any more money for family practice than the $5 million per year. So $6,200 per resident for family medicine, and $75,000 per resident for the GME expansion residents. There's a big difference there. And any new programs coming into family medicine, I hope I'm not saying more than I should, but it does affect everybody, because it increases the number of residents that are divided into that static level of funding. So there are a lot of different angles to it. So just wanted to mention it this time so you all can kind of think about it between now and the end of May. And I'd be happy to answer any questions. Did I speak about the permanent fund? No, you had a question about the permanent fund.
I did. I just wondered whether or not how the CV will help programs mitigate risk with regards to accepting a resident for 3 years.
Or 2. The legislature did create the permanent fund for GME in the 2015 session. And actually, for this biennium, 18-19, we received money from the permanent fund. It was about $11 million each year of the biennium. So of the $97 million we had for these 2 years, $22 million of that was from the permanent fund. But it's still appropriated on a 2-year basis because
Has it been
it's...
utilized in full, or is there, in that fund, are you able to keep a certain percentage?
Well, that's a very good question. The programs or the coordinating board?
The coordinating board.
The coordinating board, yeah, yeah. It kind of depends, and we are still actually figuring part of that out because this is the first biennium we've done that. Our understanding now from our financial services people is that if the coordinating board does not award all of the funding, it will go back to the permanent fund and stay there and just be reinvested. But it's the first year of the biennium, we did it the opposite way, so it's still in process.
It may not fully answer your concern, though, it doesn't sound like.
There's no answer. There's no
Yeah.
answer to that. I mean, other than it's going to be on a 2-year basis, but the intent of the legislature, and we've been saying this since 2014 when we've made the first awards, is that the GME Expansion Initiative is meant to be an ongoing program. But there's always the but, yeah.
That's all you got? Good, okay. So now we're on item number 10, talking about the consideration of future agenda items, and we've kind of already alluded to one of the hot issues out there is what to do with the programs that have passed that 3-year mark, and we'll consider that at the next meeting. By the way, that'd be great. So Suzanne said she'll send out some information ahead of time to kind of prep us up for that discussion when we come together. Yes. So we kind of have a feel for what that looks like. And I'm not even sure I know all the programs. I don't think I know a few of them, but that'll be good to see that information. By the way, that meeting is scheduled already for May the 29th, which is a Wednesday from 10 to 12. So be sure you mark that down on your calendars. We need you here so we can have that discussion. And it will be here. Mm-hmm. And there's a note here saying that afterwards we're going to get to recognize Dr. Gertz for his service.
He's going to be here.
So be sure to be there for that too. Dr. Gertz has done a great deal of service for this group over the years in family medicine in Texas. So we'll be able to honor him, which will be good. Looking forward to that. So that's great. Any other issues that we need to think about and put on the agenda for the next meeting? You all can think of?
I have a couple.
Okay.
Also like to think of. So I guess going back to the financial report, whoever did that, great. It's a lot of phenomenal work. I appreciate it. I love these operational averages parts at the bottom, but I think it would be helpful for me to have this all on one page and compared over either the previous bienniums or previous years. Sure. Because seeing trends, it's hard to see trends with this particular type of report. So that would be a suggestion.
So I have a question about that. Would you want to see the averages trended over the years, maybe?
Yeah, just something very simple like that.
Get our arms around the data. That'd be a good way to go, potentially. So I think that's an interesting idea. We have that data.
But,
Oh, yeah.
Yeah.
But on the averages
Yeah.
for each page.
Yeah.
Another suggestion that I had is I would be interested in confirming my suspicion with regards to the number of family medicine GME spots that have been present over the last 20 or 30 years. In my little research, it's almost stagnant. I don't know that because of programs that have come on and programs that have closed, that the total number of positions have remained the same. Now that I'm happy to see that we're expanding GME a little bit more, I think it'd be nice to kind of have a picture of what that is about. Because if no one has taken a look at it, there is a great report from the Texas Health and Human Services that came out in July 2018 titled Texas Projections for Supply and Demand in Primary Care Physicians and Psychiatrists 2017-2030. That is both an eye-opening report, somewhat scary report, and pretty much says that the only way that we're really going to get out of a deficiency in the number of providers, unless legislation changes what is a doctor, how soon they can get licensed and the like, is expanding GME slots. So I'm happy that they're doing that, but I think that we could do a better job of tracking that moving forward as we go forward, and there's more, hopefully more family medicine positions opening up with that expansion. And then one final request would be, I know that at the last time that we had a vote with regards to how much programs we're going to get, there were different options with regards to how much was divvied up with regards to whether or not it was the Faculty Development Center and the like. I would like to have the option also included of programs that have gotten GME expansions, such as myself, having those numbers not count towards the family medicine grant. Because if you're getting a grant already at one point, I'm just trying to figure out, you know, are we double dipping or the like if you're applying it to both? So it'd be nice to have some clarification on that part, as well as having an option, because if a program is committing to expanding and there's a certain level of funds and the overall number of residents are going to expand, these other programs that are going to have to deal with a lowering number of, you know, if you're having 50, 60 more slots, this number is going to get smaller and smaller for those programs that don't have the funding or whatever to be able to expand. I don't know if that's clear. I can write it in an email if need be. Okay.
Okay, so a couple of other things to include into the agenda next time. Any other issues that want to be brought forward by the group? Okay, well, hearing none, I think we'll close that particular item, and we're down to item 11, which is adjournment. And so I want to thank everybody for attending and participating actively in the discussion. I think it was a good meeting, and we'll see you guys May 29th. Thank you.
Thank you. Bye-bye.